point of time, this slide is depicting certain cardiac events which take place in a cardiac cycle, and that cardiac cycle, which involves systole and diastole, has certain electrical activities. Those electrical activities, when we trace on a paper, ECG paper, we have certain waves. And there is an isoelectric line, a straight line. Certain deflections are upwards, they are positive, and certain deflections are downwards of that baseline or isoelectric line. So they are negative shifts or negative deflections we have. So we have been talking about, looking at this particular diagram of the heart. Distinctly we find the heart has upper part which includes two atria, right atrium and left atrium. And we can see here these dotted lines, they go to the electrical tracing, which starts as a P wave and PR interval. From onset of P wave to Q wave, we have PR interval, and this is the P wave to start. It means any activity which is taking part or occurring in the
Right.
upper part of the heart, or you can say in the atria, both atria, that complex is registered in PR intervals time. That particular line which shows the PR, that shows the events, electrical activities which are taking place in the right and left atrium. So there is a contraction. There is a contraction. The P wave is the systole of atria. When the atria contracts, it generates depolarization, and because of depolarization, we have the P wave. And then the wave, which is started from the sinoatrial node, reaches to the AV node. There is a small, you can say, resistance which doesn't allow the electrical current to pass to the ventricle, to the bundle of his immediately, but it takes some time. And that time, apart from P wave, we have PR interval. This is the time we have. So this is a complex. PR interval is a complex which indicates us the activity of atrial activity, right and left. And once it goes to the bundle of his, it travels to the right bundle branch and left bundle branch, which ultimately goes to the left ventricle and right ventricle. And there are finer elements of these particular fibers. They are Purkinje fibers. So they are going to activate the muscles which are present in the ventricle, which includes right and left ventricle. That component is QRS complex, Q, R, and S complex. That complex indicates the ventricular contraction, means systole, ventricular systole. Thereafter, what happens? That repolarization occurs. Repolarization occurs from ST segment. We can have the T wave. The T wave indicates repolarization of the ventricular muscle mass. But you will say, if we have the P wave, then where is the wave which should be indicating repolarization of the atria? But please remember, those particular waves, those particular things have been embedded in the high electrical activity which is taking place in QRX complex. So it is hidden in QRX complex and we cannot see. Now, ST segment and T wave has great significance in terms of repolarization. And if the repolarization is not taken in a proper manner, there is some problem with the heart muscle or their blood supply, indicating that if they are starving of the blood, they are not being able to function normally. But however, we'll see this U wave here, which again is a small wave which is coming up, and it is the repolarization of subendocardial tissue. innermost layer of the heart muscle. So heart has got three components. You can say pericardium, myocardium and endocardium. जब कभी हम मायोकार्डाइटिस की बात करते हैं, इन्फ्लेमेशन की बात करते हैं, तो इन्फ्लेमेशन आपका पेरिकार्डियम में भी हो सकता है, मायोकार्डियम में भी हो सकता है, एंडोकार्डियम में भी हो सकता है। और एंडोकार्डियम का जो हिस्सा है वो वॉल्व से रिलेटेड है, इस वजह से वॉल्व में भी सोजिश हो जाती है मायोकार्डियम में, खास करके एक बीमारी जिसका नाम है रूमेटिक फीवर। सो रोमैटिक फीवर में जहां पर जब सोजिश हो जाएगी, जहां पर वॉल्व है, ये बाइकस्पिड वॉल्व है, ये ट्राइकस्पिड वॉल्व है, तो ये सोजिश होने की वजह से जो टिश्यू आ रहा है, साइनोएट्रियल नोड, एट्रियोवेंट्रिकुलर नोड, बंडल ऑफ फिश जो आ रहा है नीचे, ये सोजिश में कंप्रेस हो जाता है। जब ये कंप्रेस हो जाता है तो इलेक्ट्रिकल करंट जो कि एट्रिया से वेंट्रिकल में जाना चाहिए, वो अपने शेड्यूल टाइमिंग को क्रॉस करने लगती है। देर इज ए रेजिस्टेंस, सो इट इज डिलेड। सो व्हाट हैपेंस, PR interval becomes more. What happens in rheumatic carditis? The very first thing happens, prolongation of PR interval. तो हमने हर चीज का एक टाइमिंग रखा हुआ है, एक सामान्य नॉर्मल टाइमिंग है। तो हमने यहां पर देखा स्टैंडर्ड टाइम जो है ये है PR इंटरवल का 0.12 टू 0.20 सेकेंड। इफ द PR इंटरवल टेक्स 2 to 5 small squares, spans approximately from 2 to 5 small squares, it is normal. And if it is extending beyond, then it is abnormal. Then it is abnormal. Similarly, if you have QRS complex, which should be having timing of 0.08 second, 0.08 second to 0.12 second. 0.12 second means small 3 squares, small 3 squares. Small 1 square is going to give us the timing of 0.04 seconds. 2 small squares, 0.08 second. 3 small squares, 0.12 second. So that is the normal. But how many small squares? 2 to 2.5. Should not be more than 2 to 2.5. Then QT interval. You can see the QT interval. QT interval, T wave. It should be 0.36 second to 0.4 second, or maximum 9 to 10 small squares. If we are having 10 small squares, they are going to make 2 big squares. They are going to make 2 big squares. Now, ST segment should be 0.20 second. ST segment should be 0.20 second, or you can say maximum 5 small squares. 5 small squares equivalent to one big square, equivalent to one big square. So these are the fixed timing which we need to remember by heart. Whenever we are going to see these waves, not only we are going to see the waves, but we are going to interpret how much time they are taking, whether they are taking within normal limits, they are within normal time frame, or they are exceeding the time frame, or time frame is less. If the time frame is less, that is also very, very important. हम वुल्फ पार्किंसन व्हाइट सिंड्रोम में देखेंगे कि PR इंटरवल छोटा हो जाता है। ऐसी कई चीजें हैं, बट जो ऑर्गन है बॉडी का, उसकी जो फिजियोलॉजी है, वो उसके बहुत से डायमेंशंस हैं। अब हम होम्योपैथिक आदमी जो है ना, होम्योपैथिक डॉक्टर वो कहते हैं सिम्टम मिलेगा। सिम्टम तो है, लेकिन देखने के लिए निगाहें चाहिए। निगाहें कैसी? टूल्स। टूल्स, ईसीजी के टूल्स आपके पास है तो हृदय में आप झांक सकते हैं। आप वो चीजें देख सकते हैं जो कि आपकी नेकेड आई कैन नॉट सी, योर ईयर्स कैन नॉट हियर, योर टच कैन नॉट परसीव। So whatever the general sensations or special sensory organs God has given us, they have a very limited kind of a reach to understand and see within the body. To see within the body what is happening, we need to understand pathophysiology. We need to understand what is the biochemistry taking place, how the organ system is working, and there you can pick up the disease. If you pick up the disease late, means symptoms are there, it is too late. आज के जमाने में symptom is not the key of disease. You have to anticipate before the symptom appears and take a remedial measure. If you are a good doctor, you will never allow a symptom to come. Should not be surprised. A symptom is a surprise. If you are treating a physician, you are looking after a family. If somebody develops any disease, probably you have ignored certain high risk features which should have given you enough time to investigate and anticipate that particular problem before it occurs. So, doctors who talk in terms of symptoms, uncommon, peculiar, rare, things are over by and large. By that time, disease is, unless it is acute, in chronic disease, you have landed up in terminal phase of the disease. And most of the time, many diseases will not give you symptom like diabetes. You will be surprised. It is a big surprise. Hypertension, silent diseases. Degenerative diseases, silent diseases, lifestyle disorders, all lifestyle disorders. Anyway, so let us go to the next slide. And I was telling you all the records which we have been looking at this particular point. This is the P wave, QRX complex, ST segment, T wave, and this is the arrow which shows from normal to absolute abnormal. Normal function of the heart, which is electrically represented by the QRS, PQRS complex, and when there is a organ damage. When there is a organ damage, you can see the electrical activity, how it is taking place. So please recall once again, because this is the normal PQRS complex, and this is here ischemia. This particular zone shows ischemia. If we have the coronary artery disease, you may not have the symptoms, but ischemia is there, then you will see T wave inversion. The repolarization is not taking place. Your muscle is not recovering from the stress which he has been undergoing while systole. It is working, but when it should get relaxation, it should get its oxygen supply, it is not reaching to it in diastolic phase, and he is not recovering. The heart muscle is not recovering. So it shows the T wave inversion. And then again ischemia becomes prolonged. You can say T wave again gone down. And then ischemia is further prolonged. T wave is inverted. ST segment, this is the ST segment which is elevating. ST segment elevation is injury. Is injury. First there was ischemia, your heart could tolerate. Now ischemia is so much that it is causing damage to the muscle. So ST segment tells you that there is a damage, and here you can say it is further gone up and is a concave upwards. Please see, this concavity is upwards. That is a classical of ST segment injury, which is damaging to the heart. And now it is the end stage where you have the Q wave. Q wave indicates there is a death of myocardium. Q wave indicates death of myocardium. ST segment elevate tells us injury, and T wave inversion shows us ischemia. All three zones are there. Whenever a tissue dies, it has got a central area of death, peripheral area is of injury, and beyond that, there is an area of ischemia, which we can see now in case of in case of a echocardiogram. And here ischemia is lack of oxygen to cardiac tissue. It is represented by ST segment depression and T wave inversion or both. Okay. Now injury will be depicted ST segment elevation and death infarct will be represented by Q wave. ये गांठ बांध लीजिए, तीन चीजें छोटी छोटी सी, अगर ये दिख गया तो ये हमारे लिए काफी इंपॉर्टेंट फाइंडिंग है, जिससे कि हम अपना ट्रीटमेंट प्लानिंग का एक बनाएंगे, कोर्स ऑफ ट्रीटमेंट प्लानिंग क्या करना है। और यहां पर हम देखते हैं आपके साथ में ये इकोकार्डियोग्राम है और ये डार्क एरिया शोज necrosis means death of the myocardium. So if you are taking echo, so this is the part which is coming here. It shows the Q wave, death part, a Q wave. ST segment shows injury just beyond death part, and this part is showing ischemia. So there are distinctly three zones. One zone where blood supply is totally cut. Because of total cut of the blood supply, the area swells, tissue swells, it secretes certain enzymes which are coming up because of that particular tissue. मतलब अगर अगर किसी घर में यंग डेथ हो जाती है तो बहुत रोना पीटना मचता है, ठीक है ना, और ओल्ड एज में डेथ होती तो कोई रोना पीटना नहीं बचता। उसी तरह से जब ओल्ड एज में किसी को मल्टीपल कॉम्प्लिकेशन से, जैसे डायबिटीज है और उसमें एमआई होता है, तो पेन ही नहीं होता, पता ही नहीं लगता। लेकिन यंग डेथ है और उसको एमआई हुआ तो आमतौर पे यंग एज में सेंसरी नर्व्स आर इंटैक्ट, सो देयर विल बी लॉट ऑफ पेन आल्सो, सो सिम्टम्स विल बी देयर, but in certain situations symptoms may not be there, but your ECG will be there to understand inside what is happening. So this wave, T wave, Q wave, shows the death of the myocardium. In between, next to the dead tissue, you have the part which is pressed upon the swollen part of the dead tissue, which is going to cause ischemia as injury, and next part is ischemia. So these are the Q waves, ST segment and T wave, which are very, very important for us to understand the pathology within. Now, the T wave, how T wave takes place. T waves occurs after a short period of rest of the ventricle. ST segment है ना, जो short period of rest है ये, और उसके बाद में रिपोलराइजेशन होता है तो T wave आपको बनती है डायस्टोलिक फेज में। और यू वेव जो बनती है लेट वेव ऑफ वेंट्रिकुलर पुरकिंजी फाइबर रिपोलराइजेशन, जो इंडोकार्डियम है, ये मायोकार्डियम है, इंडोकार्डियम में जो पुरकिंजी फाइबर्स है, when they get repolarized, U wave occurs, and it occurs just after the T wave. नाउ रेट, अब ईसीजी देखते हैं तो हम सबसे पहले देखते हैं रेट। आप ईसीजी मशीन जब भी चलाते हैं तो उसको अप्रोक्सीमेटली जो स्टैंडर्ड है 25 मिलीमीटर पर सेकंड पे रखते हैं। दूसरी सेटिंग हम इसको 50 मिलीमीटर पे भी कर सकते हैं, लेकिन स्टैंडर्डाइजेशन जो है वो 25 मिलीमीटर पर सेकंड पे रखा होता है। सो ईच स्मॉल स्क्वायर इज 0.40 millisecond. Please remember timing. Each small second represent, a small square represent 0.40 millisecond, and each large square, 5 small squares, is equivalent to 0.2 second or 0.20 milliseconds. ये 200 जाना चाहिए कि 20 जाना चाहिए, ये 0.20 जाना चाहिए शायद। हार्ट रेट जो है हमारी, we can divide 300 by the number of big squares between two QRS complex, or you can say count the number of QRX complexes in 6 seconds or 30 large squares and multiply by 10. But the best method is divide 300 big squares with each QRX complex. तो उसको इस तरह देख सकते हैं, ये R wave to R wave is one QRX, one cardiac cycle. One cardiac cycle is from R wave to R wave. So if you count 5, 1, 2, 3, 4, 5, so this is 5 includes one big square, one big square, second big square, third big square, fourth big square, fifth big square. So if two RR waves in between have 5 big squares, we can divide 300 by 5. We can divide 300 by 5 and you will get your heart rate. So 5 छक्के 30, तो 60 बीट्स पर मिनट आ गया. अगर यहां पर देखिए हम, अगर हमारे पास 5 नंबर ऑफ बिग बॉक्सेस, यहां पर जो 5 है, 5 नंबर ऑफ बॉक्सेस फॉर वन कार्डियक साइकिल. सो इफ वी आर गोइंग टू डिवाइड 300, we'll get 60.
Yes.
If we have 4 big squares, if R wave could have been here, so by 4 we have 75 beats per minute. If we have only 3 small big squares, then heart rate will be 100. If we have only 2 beats, 2 big squares, RR wave, then we have 150. And if we have R wave, and here there could have been R wave, so heart rate could have been 300 beats per minute. So this is a very simple way of calculating, and I don't think we have to go for anything beyond that. We have to remember one method, and that becomes good for us and easy for us to recall. Otherwise, you can remember in your mental picture, you can create, if R wave could have been here, to 300 beats per minute. If R wave could have been here, 150 beats. If R wave could have been here, 3 big squares, heart rate could be 100. And out 4, there was 75. And 5 big squares, 60 beats per minute. That way, roughly we can just pick up the heart rate looking at the ECG, looking at the QRS complex. Okay.
Yes.
That is the trick one has to remember like this. Now, how we will see the 12 lead ECG, what we generally see, how the lead 1 is depicted. Lead 1 is P wave upright, QRX complex upright, ST segment in isoelectric line, and T wave is upright. This is a normal configuration which we are going to see in a ECG strip in lead 1. In lead 1, which unites right upper arm and left upper arm. Now we go to the second lead. It will be also similar, but R wave is more prominent. P wave is also more prominent, and T wave is also more prominent. So you will see, if you could have seen ECG, you will see on the base of the ECG strip in 12 lead ECG, it runs independently, and that is lead 2. This lead 2 is known as key lead. This lead 2 is known as key lead, and उसको rhythm strip भी कहते हैं. ये rhythm के लिए रखी जाती है. ठीक है. Lead 3, we have similar, just like lead 1, it is almost similar to it. Okay. AVR is cavity lead. आप समझ पा रहे हैं cavity lead क्यों कहते हैं इसको? आपको याद आया कि cavity lead क्यों कहा जाता है? पूरा का पूरा lead 1 है, लेकिन ये उल्टा हो गया है. P wave is inverted, QRX complex is inverted, T wave is inverted, AVR. ये यूनिपोलर लीड है. AVR, augmented vector right arm. ओके, इन्वर्टेड है ये टोटल, इसको कैविटी लीड कहते हैं. AVL is, we have P wave inverted. It may not be inverted. Here it is inverted. RSR पैटर्न है, RSR पैटर्न, T wave अपराइट है यहां पर. वी हैव AVF. AVF देखें बिल्कुल लीड 3 की तरह दिख रही है, लेकिन लीड 2 की तरह भी दिख रही है, लेकिन QRX कॉम्प्लेक्स जो है बहुत ज्यादा पीक्ड नहीं है जिस तरह से यहां पर पीक्ड है कैविटी लीड में. V1 is a chest lead. Chest lead, P wave upright. This is RSR. So R wave is small, S wave is deep. What we see here, S wave is deep. Then next, R wave is slightly prominent, still S wave is deep. Now roughly in V3, R wave has become much more prominent, and more or less at this point of time, you may find the R wave is equal to S wave, more or less. And then V4, R wave is prominent, S wave is small. And in V5, R wave is prominent. And next we have the V6. This is R wave is prominent. So there is a transition. In transition, this small R wave becomes bigger and becomes biggest in V6. And here you will see the S wave, which was strongest and biggest wave in V1, vanishes, almost vanishes in the V6. So this is a normal ECG, 12 lead ECG, lead 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So such ECG can be called as a normal ECG. लेकिन इसका मतलब ये नहीं है कि नॉर्मल ECG है तो सब कुछ ठीक है. समझ गए? आप ये समझिए कि 50 से 60% केसेस में, आप 70% केसेस में नॉर्मल ECG होने के बावजूद भी कोई प्रॉब्लम हो सकती है. आपको फर्दर इन्वेस्टिगेशन के बारे में सोचना चाहिए. अगर कोई पेशेंट आपको लगता है कि वाकई उसको कोई प्रॉब्लम है, आप ईको करवा लीजिए, आप कुछ और भी देख लीजिए, ज्यादा अच्छा है. स्ट्रेस ईको कर लीजिए, TMT कर लीजिए. अब हम कुछ वेव्स के माध्यम से समझने की कोशिश करेंगे कुछ पर्टिकुलर चैम्बर्स की प्रॉब्लम को. सो लेफ्ट एट्रियल हाइपरट्रॉफी, राइट एट्रियल हाइपरट्रॉफी, right ventricular hypertrophy, left ventricular hypertrophy, and right ventricular strain, left ventricular strain. ये क्या चीजें और कैसे हम देख पाते हैं? तो यहां पर हम देखेंगे लेफ्ट एट्रियल हाइपरट्रॉफी के बारे में. लेफ्ट एट्रियल हाइपरट्रॉफी, तो आमतौर पे लेफ्ट एट्रियल हाइपरट्रॉफी कब हुआ करती है? तो एक बड़ी सामान्य सी बीमारी, बहुत करके आज से 30-40 साल पहले बहुत ज्यादा देखने में आती थी, रूमेटिक हार्ट डिजीज, जिसमें रूमेटिक फीवर होता था, माइट्रल स्टेनोसिस हो जाया करता था. तो उन लोगों में ये माइट्रल स्टेनोसिस में एक पी वेव का कॉन्फ़िगरेशन में कुछ डिफेक्ट आ जाता था, जिसे हमने कहा पी माइट्रल. So in ECG, we could pick up there is a problem with left atrium. So what is the configuration which you will see in ECG? The ECG will show you the P wave which has got a configuration like M. और इसको हमने M की वजह से P mitral कहा. The P wave which has been having M-shaped configuration, so it is a P mitral. अब P mitral कहाँ देखेंगे हम? So it is indicative of bulky left atrium, most commonly in left atrial hypertrophy, mostly due to mitral stenosis. And mitral stenosis is because of rheumatic heart disease, valvular heart disease. And valvular heart disease can be congenital also, can be acquired also. Here it is a acquired heart disease because of rheumatic fever. So this is the configuration of P wave. Can you see? This M-shaped configuration is of P wave. So where we can see? We will see in lead 1, in lead 1, lead 2, lead 2 is key lead. Lead 2 is very important for us, which we consider key lead, and we can also see in AVL. So these three areas, even you will find in V1 also. Chest lead also will be depicting it. But then apart from other local leads, we have more important leads, lead 1, lead 2, and lead AVL. These three leads are very, very important to pinpoint P mitral. Now, this particular area, you can see this is right atrium, this is left atrium, right ventricle, and right left ventricle. All the both chambers, they have the equal volume. Please remember, their volume is same. But here we find left atria has got bigger volume because there is a constriction of the aperture which allows atria to communicate with the ventricle. So blood cannot go easily. So atria has to contract with the power and it has to use extra power. So muscles they become big and that particular atria also dilates. Apart from that, there is a regurgitation. Mitral regurgitation also takes place during left ventricle contraction. There is a regurgitation of blood to the left atria, so its volume becomes more, so its size becomes more, its muscle mass becomes more. Okay, and that's why you will see it will show its configuration like this. This initial wave is depicting initial P wave is depicting right atrial activity, and this second part is depicting left atrial activity. So at times you will find in V1 to V3, it may appear biphasic. It may appear biphasic initially when the sinus node discharges the electrical impulse, it spreads to the right atrium and it will be registered as upward positive deflection. But same time when it goes to the left atria, because left atria is bigger in muscle mass, so electrical forces move from the right atrium to backside. So it will go into the negative area and you will see this type of biphasic presentation of P wave in V1, V2, maybe V3. Okay. But classical mitral, P mitral will be in lead 1, lead 2, and AVL. Biphasic may be seen in cases of V1 to V3 chest leads. Now, very important medicine homeopathically, whenever you have this kind of problem, you have Laurocerasus is the medicine. Because there is a strain to left ventricle if there is a regurgitation, and regurgitation is marked, then left ventricle also enlarges, left atria also enlarges. If the left atria enlarges, it is going to put the resistance to the lungs. Their lungs will be congested and right ventricle has to work more thereafter. So this is P mitral is a very important finding in the left atrial hypertrophy. Now we go to the right atrial hypertrophy, which we call P. pulmonale. P. pulmonale. P. pulmonale usually occurs in chronic bronchitis, bronchiectasis, emphysema, maybe COPD, obstructive airway disease, because there is resistance in the lungs, and that resistance is met by right ventricle. Right ventricle enlarges. Not only right ventricle enlarges, but blood also gets accumulated in the right atrium, so right atria also get involved. And its enlargement, right atria's enlargement, is depicted in peaked and big P wave. Its timing is same, but it is peaked up, and this peaked up can be more than 2.5 small squares. 2.5 small squares. Where we are going to see in key lead, means lead 2 and lead 3 and AVF. And AVF. Lead 2 and lead 3 are bipolar. AVF is unipolar. Now, we can see here how it occurs. It occurs, right atria is predominantly, and left atria is not that big. So whether you are looking in V1, V2, V3, you will find this configuration, and you will not get the configuration at what we have been looking at. Biphasic P wave will not be visible. Biphasic wave will be visible only in cases of P mitral, but in P pulmonale, you will have only tall P peaked waves in lead 2, lead 3, and even in V1, V2, V3. V1, V2, V3. Now, this is an indication of congestive cardiac failure, right ventricular enlargement and failure. In what is the commonest complication of chronic bronchitis with emphysema? Cor pulmonale. So P pulmonale tells us about cor pulmonale, and we are going to see in Kent repertory congestive heart failure, and we will get important. Sorry, here it is from Robbins, and we are looking at aconite, eposinum, cratagus. Blue is also there, strangely. Lilium tip, nux, moschata, pulsatilla. Sometimes you will find very irrelevant medicines may also come, but cratagus and eposinum is one of the very important. Adon is also very important remedy here. And other symptoms will be there, like palpitation, pain, dyspnea, and they can also be seen similar symptoms in fatty heart disease, myocarditis, symptoms especially what I am talking about, not the P wave. So P pulmonale is classically seen is right atrial hypertrophy. Let us see the right ventricular hypertrophy now. Right ventricular hypertrophy, we'll see the waves which are going to tell us the activity of the right ventricle. So those particular waves are much more visible, especially in the unipolar leads V1 to V6. Nevertheless, they may be also visible in lead 1, lead 2, lead 3. Large R wave, here we are not giving much significance. You will see only V1, V2, V3, V4, V5, and V6. So right ventricular hypertrophy, large R wave in V1. Can you see in V1 large R wave? There is very small, this is P wave here, and P wave is inverted. Can you see in V1 P wave is inverted? Please remember, P wave may be inverted in lead 1 and T wave may be inverted or flat in V1. So don't give much significance to P wave at times. Anyway, here P wave is inverted here and R wave is bigger. Can you see this R wave is one big square, second big square, half and half this. So three big squares, one, two, and three big squares. So three big squares means roughly 5, 10, 15, small 15 small segments, 15 small segments. And then you will see S wave in V5, S wave in V5, 1, 2, and 3. 1, 2, and half year 3. So 6, approximately 30. It should be more than 35. Basically it is not showing that particular criteria, but then more than 35 qualifies for right ventricular hypertrophy. However, there are other features. You can see the ST segment and T wave inversion, ST segment depression, T wave inversion, ST segment depression and T wave inversion here. So this shows the ventricular strain. So this kind of a feature where there is a ST segment depression, T wave inversion is present, that shows the strain. So right ventricular strain and this configuration of R wave prominent, very prominent, and S wave is very prominent in V5 or V6, goes in favor of right ventricular activity. Right ventricular activity is dominating, rather where the left ventricular activity should have dominated in V6 and R wave should have been upright. There should not have been the S wave. So this configuration, this especially I am talking about V1 and V6 or V5 leads. This configuration along with QRX complex, R wave prominent in V wave, S wave prominent in V5, ST segment depression, T wave inversion, everything goes in favor of right ventricular hypertrophy, strain and ischemia. Strain and ischemia. So whatever may be the reason here, there is a right ventricular hypertrophy, and the right ventricular hypertrophy can occur because of there can be ventricular septal defect, or there can be cor pulmonale, or there can be aortic stenosis, sorry, pulmonary stenosis. The pulmonary artery which goes to the lungs, if it has got pulmonary stenosis, the valvular stenosis, even then you will find right ventricular hypertrophy. So it gives us the clues. ECG gives us here clues that there is a right ventricular hypertrophy. So very first thing I am going to examine the chest, whether the chest is emphysematous, whether the patient is being a smoker, whether the patient has got more than three episodes every year continuously for 3 years. So he is a fit case for diagnosis of chronic bronchitis, whether he has got clubbing, whether he has got cyanosis. If clubbing is present, cyanosis is present, and he has got this kind of a feature, I will say he has got chronic bronchitis with emphysema with carpulmonale. But if I get a murmur which is present in the parasternal region and which is systolic murmur, I am going to say it is because of ventricular septal defect. If the murmur is present in the left epicardium, left second intercostal space, and it is a systolic murmur, I am going to diagnose it as pulmonary stenosis. You see, and if at all we have certain other pathologies, I may not be sure about it, but then there can be something else also present. So that needs to be kept in mind sometimes. So here depressed ST segment V2 to V4, and we can see here these two diagrams which is depicting heart. Here it is a normal heart. The right ventricular wall is comparatively, if you see the left ventricular wall is 3 times thicker than the right ventricular wall, because right ventricle has to push the blood to the heart only, lungs only. So it doesn't have to generate much of the force. but left ventricle pushes the blood through aorta through the whole of the body. So it requires to generate much bigger force. And systolic, you see 120, but systolic may not be that kind of systole in right ventricular contraction. So there is not a bigger muscle mass. But in case when it has got right ventricular hypertrophy, here you can see the heart muscle is 3 times more bigger than the left muscle. Left ventricular wall is not all that bigger, as you will see. Right ventricular muscle mass is big, and because of right ventricular muscle mass, it has been able to generate lot of electrical activity, which is going to show in the waves, which are the area of right ventricular activity, especially V1, where it should have been small R wave. Here we have a big R wave. So this is one thing which we have to understand. And even in congestive cardiac failure, initially there will be hypertrophy and there will be failure, means later stage when there will be dilatation. Initially there is a muscle mass builds up, and muscle mass required lot of nutrition, blood supply, but it is not sustained for the long time. Gradually that muscle mass becomes a burden and heart dilates, so failure starts. But failure is a very terminal stage. Initially it is hypertrophy. Again, we can remember the same drugs we have taken which were there for left atrial hypertrophy, most probably. Let us see the left ventricular hypertrophy. And here what we'll see, this is, it looks like uh, lead 1, lead 2, lead 3. This is lead 1, lead 2, lead 3. AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. V1, V2, V3, V4, V5, V6. So S wave prominent in V wave. Can you see the S wave prominent? This is S wave. This is S wave. S wave is prominent because the major muscle mass is the left ventricle and electrical forces are going towards the negative side. R wave is because of electrical activity in right ventricle. Here again, V2, we find right activity, right ventricular activity, R wave is slightly prominent, and V3, R wave is still prominent, but suddenly you will find the R wave becomes much more in the V4, V5, and V6. And V4, V5, V6 looks into the left ventricular muscle mass. So S wave, here it was depicting the activity which is negative electrical forces in V1 lead, specifically is showing left ventricular activity, and in V3, V4, V5 R wave is showing electrical activity in left ventricle. So here these wave patterns are itself diagnostic of left ventricular hypertrophy. One more important thing, when we are looking at this particular point, lead 1, lead 2, and lead 3. So lead 1, R wave is upright, and you see lead 3, S wave is up, downward, S wave is prominent, no R wave. So both the waves are not looking towards each other. They are looking on the opposite direction, and such an event is present when there is a axis deviation. It is called as left axis deviation. Lead 1, lead 2, and lead 3, if we have R wave prominent in lead 1 and S wave prominent in lead 3, like this, what we are looking at this shows left axis deviation. And left axis deviation is one of the causes of left ventricular hypertrophy. So here we have three clues. Number one, lead 1, lead 2, lead 3 tells us that there is a axis deviation, left axis deviation. Suddenly we think one of the causes could be, yes, left axis deviation is left ventricular hypertrophy. And then we look at the lead V1, we find S wave is deep and V6, R wave is far, far superior. So this points to the ventricular activity. So our confirmation goes in favor of left ventricular hypertrophy. So here S wave prominent in V1, R wave prominent in V5, V6, and V4. These are the precordial leads, and approximately V5 should be more than 26 millimeters, and sum of S wave in V2 and R wave is more than 36 millimeter combined. Then you will have the probability to on ECG to comment as left ventricular hypertrophy. And here again, the muscle mass, you can see how the muscle mass is much more thicker in the left ventricular walls. Hypertrophy of the heart is mostly we talk about in terms of left ventricular hypertrophy. So these are the medicines: arum iodide, bromium, cactus, tretigus, digitalis, calimur, lacusis, lithium, rustox, spigelia, whatever medicines they are. But once there is established left ventricular hypertrophy, this is a late stage of diagnosis, and there is, whenever hypertension occurs, the target organs, they start having some sort of a damage. So target organs are: number one is the heart itself, number two is eye, number three is, you can say, kidney, and number four is brain. So there is a race. Who is going to kill the patient? So heart says, I am going to kill the patient. So it is because of hypertension, coronary artery disease, and myocardial infarction will be there. If you have some casualty, initial casualty, that is the target organ, heart itself. So what is the casualty? Right left ventricular hypertrophy itself is the first casualty, target organ damage. If you see the kidney have hypertensive renal diseases, you have retina, stage 1, stage 2, stage 3, retinopathy, hypertensive retinopathy. It is easier to see the retina and pinpoint since how long there has been a hypertension. And we cannot see the brain, but we can see the blood vessels in the retina, and blood vessels in the retina are coming directly from the brain itself. So looking at the status of the blood vessel, retinal blood vessels, we can imagine what is happening inside the brain. So that is a true index looking at the retina. Anyway, these are the remedies generally which we can see in homeopathy. And at this particular point of time, you have to prescribe the medicines which should be in the physiological doses, means mother tincture. You cannot prescribe potency, and potency will not be able to give you that kind of a benefit. So friends, looks like we have the time 10. So we are going to just finish over here only.
Yes, sir.
So let us uh, call off the day at this moment. तो फिर अगली बार में मैं कोई दूसरी एक आधी, ये मोटी मोटी सी चीजें हो गई हैं करीब करीब, तो इसको ध्यान में रखते हुए अब कोई और देखेंगे, कोई और टॉपिक अगर आप पसंद करें तो
Yes, sir.
मैं आपको इससे रिलेटेड एक, क्योंकि नाजा का जिक्र यहाँ पर कितनी बार आया है मैंने देखा नहीं है। नाजा बहुत अच्छी मेडिसिन है।
Nausea tea,
नाजा
night rest.
बहुत अच्छी मेडिसिन है हार्ट की। तो
Hmm.
मैं आपके साथ में, अगर आप टाइम देंगे तो मैं कोशिश करूंगा कि जैसे मैं पढ़ना चाहता हूँ नाजा को, मैं आपके साथ में उसको आपके साथ में शेयर करना चाहूंगा। नाजा,
Yes, sir. Yes,
वी
sir.
वुड लाइक टू शेयर अवर सेल्फ कि कैसे हम पढ़ते हैं नाजा। तो यहीं पर समाप्त करते हैं। थैंक यू वेरी मच।
Thank you, sir.